Kamath. Dr. Kamath is a radiation oncologist with Diablo Valley Oncology Hematology.
Thanks, Joan. Can you guys hear me? There we go. All right. Well, it's really an honor and a privilege to be here with all of you today to help us celebrate survivorship. First and foremost, I want to congratulate each and every one of you survivors that's out there today and your cheerleaders that are with you as you've gone through this journey. A lot of people that go through the cancer experience after they're done with their treatment don't want to talk about what they've been through. A lot of them don't want to think about it. So I appreciate you guys coming and participating. In the last 15 to 20 years, we've made some great strides in breast cancer treatment. We've made vast breakthroughs in surgery, in radiation therapy, in systemic therapy, and by that I mean chemotherapy, hormonal therapy, other targeted therapy. But if you look in the last 5 to 10 years, I think we've placed a greater emphasis on quality of life issues in survivorship. And as we've talked about already, because we've got more breast cancer survivors than ever before, we're starting to see some of those long-term complications, and we're trying to figure out how our survivors are going to be able to deal with some of these issues and how we can help them deal with some of these issues. When we talk about breast cancer therapy, I like to break it down into local therapy and systemic therapy. When we talk about local therapy, we're typically talking about surgery and radiation therapy. When we talk about systemic therapy, we're really talking about total body treatment. So we're talking about chemotherapy, hormonal therapy, and other what I call medicinal therapy. We'll talk about targeted therapy. Today, if you look at the improvements that we've made in each of these arenas, and we'll talk specifically about each of these three categories, we see that today more than ever we are paying attention to the long-term complications that we cause with each of these treatments, and whenever possible we try to avoid these long-term complications. With regard to surgery today, I think more than ever, whenever possible, organ preservation and maintaining functionality is very, very important. Today, more than ever, we're catching breast cancers in the earlier stages, and whenever possible, we try to save the breast. We try to do lumpectomies and radiation to try to preserve the breast. Sometimes we're not able to do that, and we'll do a mastectomy, and whenever possible, we try to do reconstruction, because the overall cosmetic result after the treatment and having a woman, and I say a woman, but breast cancer affects men as well. And so for both men and women with breast cancer, the cosmetic outcome is important, and we have to think about it. When we talk about surgery for breast cancer, a couple of issues that we need to highlight are, number one, a lot of men and women that go through the surgery end up dealing with wound healing issues. Today, more than ever, our techniques have become less invasive. We don't do any more surgery than is absolutely necessary. The goal, of course, is to remove the cancer in its totality and to get clear margins. But we really try to pay attention to not removing any more tissue than is absolutely necessary. Lymphedema is another issue that has come up over the years, and I know there's some of you out there in the audience today that may have lymphedema. And we've learned that the more lymph nodes that you take out, and especially if you have radiation therapy after you have lots of lymph nodes taken out, you can increase the chances of having lymphedema. It used to be, up until 10, 15 years ago, when surgeons went in to remove the lymph nodes, They would just go in and just grab a handful of nodes, not really knowing how many they were going to remove. Today, we have some great ways to limit the number of lymph nodes that we take out. Most women that have had their treatment in the last 5 to 10 years have probably had something called sentinel lymph node mapping done. And that's something that has really helped us in that area. Overall, I would say that with surgery, the goal has been to try to preserve the breast whenever possible, use some of these lesser invasive techniques to make sure that after the surgery we have good wound healing so that we can move on to the next important steps. With regards to systemic therapy, chemotherapy, hormonal therapy, realize that we're wanting to treat any cancer cells that may be hiding anywhere in the body. And today, more than ever, we're focusing on targeted therapy, which really means you have chemotherapy drugs, hormone drugs, and other medicinal drugs that specifically target the cancer cells. We want these medicines to chase down the cancer that's hiding anywhere in the body, but we don't want these medicines to affect the normal healthy cells. And so Tiffany has mentioned a couple of those medicines, and what I can tell you is that today we really try to limit some of those side effects that are typically associated with systemic therapy, in particular the chemotherapy. Today we try to anticipate what sort of side effects a man or a woman may experience as they go through breast cancer therapy. And oftentimes, and I would say it's the norm today, that we will use certain medicines and certain techniques to help limit some of those side effects and the potential to cause long-term complications. With regards to radiation therapy, I think I would say that probably of the 3 areas that we've talked about so far, surgery, systemic therapy, radiation therapy, probably the most drastic and perhaps the most impressive advances have occurred in the radiation therapy field. I think all of us have seen sort of what has happened with computer technology in the last 5 to 10 years. It's pretty amazing. Even today, it just blows my mind when I think about what I do every day. But radiation therapy has gone from being from having this stigma of being something that is very dangerous. We've always been told to stay away from radiation. There's all sorts of bad effects from radiation. And so when my patients come to see me and they say, "You're going to do what?" And after we talk and I explain what it is that we do with the radiation, how it works, and our experience over the last 80 to 90 years using radiation, most men and women feel very comfortable with it. Today, more than ever, we have the ability to focus the radiation much more precisely than we ever could on the target that we want to treat. I should say target or targets that we want to treat. In particular, when we talk about treating breast cancer, we're dealing with issues where a woman that's had a lumpectomy to try to save the breast for breast conservation therapy, a woman will come to see me to talk about getting some radiation therapy afterwards to basically get rid of any microscopic subclinical disease that may be hiding. Today, we have the option of doing what we say is whole breast radiation, which is treating the entire breast after a lumpectomy to make sure that if there's any cancer cells that are hiding, we get rid of them. There is also the option of doing partial breast irradiation, which is basically just treating the lumpectomy bed. This is something that has gained ground in the last 2 to 3 to 4 years because we have the ability to focus that radiation much better. I would say to you that not all women are good candidates for partial breast irradiation. Certainly if I were a patient and going through this, given the choice of 6 weeks of radiation versus 1 week of radiation, I mean, I would take that in a heartbeat. But we really have to look at the long-term control rate and the cure rate, and we know that there are some women that are great candidates for partial breast irradiation, but we know that probably the majority of women after a lumpectomy would actually do better with whole breast radiation. And so we will talk about that. Today, when we do radiation therapy, we're not thinking in terms of 2 dimensions or 3 dimensions. Back in the 40s, 50s, 60s, we did 2-dimensional therapy where we used x-rays, top, bottom, right, left. And then we started doing 3-dimensional therapy where we started using CAT scans and MRIs and really tried to picture our target in 3 dimensions so we could pinpoint the radiation. Today, what we're doing is 4-dimensional therapy. The 4th dimension being time, and realizing that over a period of time, different parts of the body move with respiration, with breathing. And so today, we actually are able to track the motion of a certain part of the body that we're treating. And so by doing that, we're able to target that area better with the radiation. So not only can we focus the radiation better, but we're also using lower doses of radiation. We've learned in the last 20, 30 years that with higher doses of radiation, there's some long-term consequences. Today, because we use other types of therapy along with the radiation, we use chemotherapy, hormonal therapy, other medicinal therapy, we don't have to use the high doses. So generally speaking, we use low-dose radiation. And that seems to have made a big difference. And what I'd like to do, and I would encourage all of you in the question and answer session to ask questions specifically about each of these different therapies that we've talked about. What I want to say is that, just in conclusion, is that as a oncologist, as a caregiver for family members and friends that have been through this cancer experience, and as a over 20-year volunteer with the American Cancer Society, I think that probably my most important goal, a personal goal of mine, is to increase cancer awareness out in the community. And I think what it's going to take, and we've realized this in the last 5 to 10 years, is that it really takes a grassroots effort. And I think the most important part of that grassroots effort is you guys, the survivors. So thank you for coming out and participating today.